Okay, so welcome everyone to our eighth weekly seminar. I hope you'll enjoy this one. We'll be going over a case study today, and we'll also be doing cystoid macular edema. We'll be going over a couple interactive situation questions of some that you might face as a medical, student, a medical doctor, or surgeon. And so it's just a nice way to get you thinking and how doctors make those, really hard decisions. And then we'll be going over our well-being officer will be talking about how to deal with grief and loss. And other than that, I do have a couple reminders. Newsletter team applications are open. So the Aspiring Surgeons Network, wants a newsletter team, and we'll be making monthly newsletters. It will have a lot of information and other external support things that you could use, like resources. And also, we're trying to make a video, which will be introducing the Aspiring Surgeons Network. So it'd be really helpful if you, are a constant participant. Um, it would be really nice if you could make a little video, and we do have the message on our WhatsApp community page. I will post it again sooner to the deadline. And we also have essay competitions coming up. More information about that later on in the next couple weekly seminars. But yeah, other than that, I'll be handing over to Neha, who will be doing the case study, please.
Today, I'll be talking about sudden cardiac arrest in young athletes, focusing on the real life case of Christian Eriksen. At Euro 2020, during a live football match, millions of people watched as Eriksen suddenly collapsed on the pitch. What happened to him and what can medicine learn from it? In June 2021, Eriksen was playing for Denmark against Finland when he suddenly fell to the ground with no contact from other players. He was unresponsive and the game stopped immediately. Teammates shielded him from the cameras whilst medics rushed onto the field. He received CPR and a defibrillator shock. Within minutes, his heart was restarted. Later, doctors fitted him with an implantable defibrillator to prevent this from happening again. Amazingly, he returned to professional football less than a year later. So, what is a sudden cardiac arrest? A sudden cardiac arrest, or SCA, is when the heart suddenly stops pumping blood due to an electrical fault. This is different from a heart attack, which is caused by blockage in the coronary arteries. In SCA, the heart rhythm becomes chaotic, usually ventricular fibrillation, meaning no blood is circulated and the person collapses within seconds. So, why would this happen to a young, fit footballer? The main causes are often hidden heart conditions, such as hypertrophic cardiomyopathy, where the heart muscle is abnormally thick, or inherited arrhythmias, like long QT syndrome. These conditions can be silent and only show themselves when the body is under extreme stress, such as intense exercise. The reason Eriksen survived is because of the immediate response. His teammates and the medics started CPR within seconds. This kept oxygen going to his brain. Then an AED, a defibrillator, was used to shock his heart back into a normal rhythm. Without that response, survival chances fall by about 10% for every minute without treatment. This is why CPR and AEDs are life-saving skills for everyone, not just doctors. One of the big debates after this incident was whether young athletes should undergo mandatory heart screening. Some countries, like Italy, already do this, but screenings can be expensive and not every condition is easy to detect. For those at risk, an implantable defibrillator can monitor the heart and deliver a shock if needed, which is what Eriksen now has. This case also raises some important ethical questions. Should all young athletes undergo heart screening? Who should pay for widespread screening programs? Should players with ICDs be allowed to continue professional sport? And how do we balance safety versus personal freedom? What Eriksen's case shows us is how vital CPR training and public access to AEDs really are. Anyone could be in a situation where someone collapses, and knowing what to do can make the difference between life and death. To conclude, Sudden cardiac arrest can affect even the healthiest young athletes. Christian Eriksen survived because of immediate CPR and defibrillation. His case opens up wider discussions about prevention, screening, and ethics. I'll leave you with this question. If someone collapsed next to you, would you know what to do? Thank you.
Thank you so much, Neha. I hope you guys found that insightful. Can we have Emma to do cystoid macular edema, please?
So, cystoid macular edema. So, we're going to go over the understanding of the formation of cysts and the treatment that is used for cystoid macular edema. So, the macula is the central part of the retina in the back of your eye. It helps you see the fine details, colors, and it also helps you see the things that are right in front of you. So the next is the RPE. So the RPE is a thin layer of cells between the choroid and the neuroretina. So the choroid is the part that provides blood to your eye, and the neuroretina is where photoreceptors are located, and those are what detect light. So the RPE has a secondary role where it provides metabolic support to the photoreceptor cells. By metabolic support, it means they help in the chemical reactions that occur in the photoreceptors, whereby light energy is converted to chemical energy. So in the image, you can see a dark brown spot in the middle of the eye. So that is the fovea. It's a small depression, also known as a pit, at the center of the retina, and it's responsible for your sharp vision. So it contains a high concentration of retinal cells, which are cone photoreceptors, which are again responsible for color and fine detail. So what is CME? CME, also known as cystoid macular edema, occurs in the macula, sorry, when fluid builds up, leading to the macular swelling and then visual disturbances like black or dark spots, blurred or wavy vision, and changes in your color perception. So mechanisms of CME. CME is caused by the dysregulation of the blood to retinal barrier, which allows proteins and other solutes to enter the retinal tissue. So the disruption of the balance in the osmotic and hydrostatic forces is what causes the fluid to enter when normal mechanisms are overwhelmed. So this is what results in the formation of intraretinal cysts and what causes the visual impairments. So there is quite a range of symptoms for CME. So blurred or decreased central visual acuity, so where objects may appear wavy or unclear. Color changes, so colors appear less vibrant or different to what they would have been regularly. Dim or dark areas, like dark spots in the center of your vision where you just can't see. Light sensitivity, so you'll be a lot more sensitive to the light. And metromorphopsia, which is distorted vision. So the causes range as well. So it could range from aging as just a natural process, inflammatory diseases such as uveitis, post-surgically through surgical complications in maybe post-cataract surgery, post-vitrectomy, or post-glaucoma surgery. It can also be caused by other diseases such as vascular diseases in the retinal vein occlusion or hypertensive retinopathy, and it can also be drug-induced through drugs like nicotinic acid. So CME can also be onset through acute or gradual. So acute onset CME is where it occurs suddenly rather than over a long period of time, and gradual onset CME is where it occurs over a long period of time. And it can also have bilateral involvement whereby it affects both sides of your body rather than one, so maybe just both eyes. So diagnosis. So you are diagnosed with CME by an ophthalmologist through special scans, which are the three on the right. So OCT, FA, and FAF. So optical coherence tomography finds the intraretinal cysts in your outer plexiform layer. It also finds the increased central macular thickness and disruptions in the retinal architecture. So disruptions in the structure of your retina, the shape of it, or maybe the thickness in the retinal layer. Then there's the fluorescein angiography. classic petaloid structure, which is the flower petal shaped pattern, produces late phase leakage, so leakage in the blood vessels or through the fluid, late phase, so late in the diagnosis of the disease. Or it also helps find the identifying underlying vascular pathology, so other diseases or things which may be wrong with your vascularity, which is the flow of your blood. And then there is also the fundus autofluorescence, which finds hyperfluorescent areas in the eye and in the retina. And it also finds RPE changes, so changes in the RPE in the layer between the retina, in the choroid, sorry, and the um, near and the photoreceptors. So there are three main treatments. So there's anti-inflammatory medications, which are just what they sound like. They're medications which reduce inflammation, which helps with these symptoms. So there's anti-VEGF injections, which are medications which help reduce the fluid leakage from blood vessels in the retina. Usually they're given monthly, and they're most suitable for CEM patients whose cause of CEM is refractory or vascular causes. Then the third is laser therapy and surgery. So laser procedures target and reduce the edema, whereas surgical treatments include pars plana vitrectomy with membrane peeling. So they peel off the individual membranes. And then there's the difference between CME and DME. So DME is similar to CME, but its causes and how it happens and occurs and what it leads to are quite different. So DME is diabetic macular edema. So diabetic macular edema, you could probably tell, diabetic macular edema, sorry, is caused by diabetes. So its cause is diabetic retinopathy. So pathophysiology. So if you look into what causes it, so chronic glycemia, which is the chronic increase in blood glucose levels, so constantly having high blood glucose levels, leads to vascular damage. So it damages your blood vessels, which in turn leads to VEGF upregulation. So too much VEGF is produced. Then the OCT pattern, which is through the OCT test, it shows diffuse thickening, so it thickens at a gradual rate, and it'll have different patterns for cysts, so you may not be able to identify cysts the same way every time. And then the FA pattern, which is, again is one of the other tests mentioned, it shows more diffuse leakage compared to CME, and it also shows microaneurysms. So CME, as you know, has a variety of causes. So its pathophysiology is so condensed breakdown of blood retinal barrier. So the blood retinal barrier breaks down, which is the RME, and leads to intraretinal cyst formation. Then you also have the OCT pattern, which shows distinct cystoid spaces, so in the outer plexiform layer, so it is quite easy to tell. And then the FA pattern, which you can see in the photo, shows a petaloid or flower petal-shaped pattern of leakage. Thank you.
Thank you so much, Ahmed. So now we're gonna go over the interactive situations that you could or might experience if you're a medical doctor or surgeon. So yeah, I would like you to respond in the chat because these are like multiple choice questions, and I want to see your thought process to why you chose that. But yeah, so situation one is a 45-year-old construction worker arrives at the ED with A&E, sorry, with A&E with severe chest pain radiating to his left arm, and he's sweating profusely and he appears really anxious. And his ECG shows some ST changes, but tropanoin levels are pending. So he mentions he can't afford to miss work and wants to leave. So just a little bit of like medical knowledge. So ST changes, if they can indicate various cardiac diseases, such as myocardial infarction, ischemia, sorry, or infarction, and tropanonin levels There's crucial indicators of heart muscle damage. So they're not beating, like the heart is not beating properly because of muscle damage. So the ECG is showing that, he might have a certain cardiac disease. So in this situation, what would you do? Would you let him leave after signing an against medical advice form? Would you insist he stays for observation regardless of his wishes? Or would you explain the risks, order immediate cardiology consult, and try to find like financial assistance because he is, anxious about missing his work? Or D? We have a couple answers. So everyone's saying C. And yeah, the answer is C. The reason for that is that the patient is showing classic signs of acute coronary syndrome. It could either be a myocardial ischemia or it could be myocardial infarction. So it is really important that, the physician, he or she must balance patient autonomy with duty of care. So option C seems like the most appropriate medical practice. And this is so the physician would try and inform, the risks of, just leaving and not looking into what's happening to the construction worker. And so this is the correct answer. Now, situation two, during a routine laparoscopic cholecystectomy, sorry, my bad, that is the removal of the gallbladder, which is used to treat gallstones. And so in that procedure, you accidentally nick the common bile duct. And so the patient is stable, but this complication will require additional surgery and extended recovery time. So what would you do? Would you continue the surgery and repair the duct immediately? Would you convert to open surgery immediately to better assess and repair the damage? Or would you stop the procedure? Or would you complete the cholecystectomy and address the bile duct issues later? Give you some time. Some people are saying A, some people are saying B, some are saying D or B. Um, the answer is B, because the the damage that this can cause needs immediate attention. And so converting to open surgery, so open surgery is where they do like a large incision into the skin or the tissue to have a better visualization of the anatomy and also the damage that was caused. So this can help with precise repair of the injured duct, and it can reduce the risk of further complications. So immediate assessment is needed of the extent of the surgery, and then the surgeon can perform the repair in the open surgery if he or she is experienced, or they can call for assistance if it's like an emergency and the patient's bleeding profusely or something. Okay, situation three. 16-year-old girl comes to your clinic requesting control. She specifically asks you not to tell her parents, citing religious and cultural reasons. She appears mature and informed about her decision. What will you do? Give you a little time to answer the question. I'd also like you to mention why, if you can. So why would you choose to do a certain action from here? Okay, so if she meets the Gillick competence assessment, then she's fit to have it. C, because I should keep the patient's confidentiality. Both of them are great options. B, she has shown that she understands the situation, and doesn't seem to be at risk of abuse. Is that abuse? Sorry, I can't really read it. And meets the Gillick competence. Um, yeah, so the answer is B. This scenario involves understanding the assessment of the minor's capacity, which you guys have done. You guys have said that, she meets the Gillick's competency. And so she should be allowed to have the birth control. And then situation 4, an 82-year-old patient with advanced pancreatic cancer is on life support. The family is divided, so the spouse wants to continue all measures, so all medical treatment, while the adult children believe it's time to transition to comfort care, or also known as palliative care, which is end of life care. Um, the patient has no advance directive, meaning he doesn't have capacity. So what would you do? Would you side with the spouse, because she's the next legal next of kin, or would you follow the children's wishes because they represent the majority? Would you continue current care while facilitating family meetings and ethics consultation, or would you make the decision based solely on like medical futility and what you could do as a medic for the patient? All of the answers that I'm having seem right, and they're all correct. It is C. And so complex end-of-life decisions such as this one are quite, like they're really the crux of medical ethics. And so ethics consultations could help the family navigate disagreements, and clear communication about the prognosis and treatment options would be needed as from you as a medical doctor, and understanding the legal hierarchy of decision making. So, like the patient's um, family who has the biggest right to make the decision for the patient who doesn't have the capacity to do so. So yeah. Situation 5, during a pandemic surge, your ICU is at capacity. So two patients need the last available ventilator. A 35-year-old teacher with COVID-19 pneumonia and good prognosis, and a 70-year-old retired physician with multiple comorbidities, and poor prognosis. So what would you do? Would you give it to the younger patient? Would you give it to the older patient, or would you? This one's not gonna lie, kind of easy. C. Okay, because it's an easy question, I would like reasoning for it. So maybe use principles or medical ethics you've learned. So this could be a question that you might have gotten in like a university interview to see your situational judgment. So, having a sort of idea of what you would say in that situation would be a good idea. In emergency situations, you must triage patients to ensure those who need immediate help and seem to be in the worst conditions are prioritized. Everyone has the right to care, so it's important to make sure we are using the right protocols. Yeah, essentially, you can't let your judgment of patients decide who gets what resource. So you do need to look at the resources you have. You need to look at triage protocols, which you will learn as you become a doctor. And you need to be transparent in your decision-making processes, and you need to avoid bias based on social worth or personal characteristics, as I mentioned before. Situation 6. You discover that a patient received 10 times the intended dose of warfarin. So warfarin is a anticoagulant drug, so it prevents coagulation of your blood. And this was due to an error that you made 2 days ago. The patient hasn't shown any signs of bleeding yet, but the labs show a dangerously elevated INR. So elevated INR levels mean that your blood isn't able to clog anymore, so it's not forming clots anymore, and so you're more likely to just bleed out. So what would you do? Would you quietly correct the medication and closely monitor the patient without telling the patient what happened? Or would you immediately inform the patient, reverse the anticoagulation, and document the error? Would you wait? Or would you blame the pharmacy for not catching the error? Exactly. I'm seeing a lot of B's, and that is the right answer. Um, so if you make a medical error, you need to be transparent about that with your patient, or if the patient doesn't have enough capacity, you need to tell the patient's family or patient's, next of kin. And you need to, have a proper documentation in the medical record, and you must try and reduce the damage that was caused. Okay, last situation before we move on. You notice a colleague appears impaired during their shift, so they have like dilated pupils, they have erratic behavior, and they're making unusual decisions. So you suspect that they may be under the influence of substances while caring for patients. What would you do? Would you confront them? Would you report your concerns? Would you wait and gather more evidence before taking action, or would you offer to get them treatment privately? Yeah, I'm seeing a lot of B's again. Um, Suspected impairment in healthcare workers requires immediate reporting to protect patient safety because every patient there has the right to the best medical care every doctor can afford to give. So if a medical doctor or any healthcare professional is suspected to be not in the best state, then that is a danger to patient safety. And so we need to take precautions for that. So patient safety obviously takes precedence over personal relationships that you might have with that colleague. All right, that's all I have for the situations. I'll hand over to Neha again for coping with grief and loss in healthcare.
Hi everyone. Today's session is about something we don't often talk about when we think about becoming a doctor, and that's grief and loss. As future medics, it's important to understand that medicine isn't only about science and treatments, it's also about people, emotions, and sometimes loss. This talk will explore how grief affects both patients and healthcare professionals, and how we can build resilience without shutting down our emotions. Grief is sometimes every med sorry. Grief is something every medic will encounter, whether through patient loss, working with families, or even in their own personal lives. Yet it's rarely discussed openly during training. If we ignore grief, it can lead to burnout and emotional exhaustion. But if we reflect on it, grief can actually deepen our empathy and make us better doctors. There are several ways grief shows up in medicine. First, there's patient grief, which is what we feel when someone we've cared for passes away. Then there's family grief, where we witness and support loved ones in their pain. There's also team grief, when an entire ward or medical team feels the loss of a patient. And finally, there's personal grief, when healthcare workers are going through their own losses while still being expected to work or study. Understanding these forms helps us see grief as complex and layered, not one size fits all. You may have heard of the Kubler-Ross 5 stages of grief: denial, anger, bargaining, depression, and acceptance. But it's really important to know that grief doesn't follow a straight line. People may skip stages, repeat them, or experience grief in very different ways. Another helpful idea is the dual process model, which says people move back and forth between grieving and carrying on with normal life. One day they may feel devastated, the next they may feel okay, and that's normal. As future medics, we need to avoid assuming how someone should grieve. There's often a belief in healthcare that you have to be tough and not show emotion. But resilience doesn't mean ignoring grief. It means finding ways to process it. When emotions are bottled up, they can turn into compassion fatigue, burnout, or even detachment from patients. True resilience means acknowledging what you feel, giving yourself space, and then continuing to care. So, what can you do now as future medics? Start reflecting, whether through journaling or just talking about experiences. Acknowledge emotions rather than judge them. Feeling upset doesn't make you weak, it makes you human. Build support systems, whether through mentors, friends, or peer groups. And most importantly, accept your limits. You can't save every patient, and that's not a failure, it's a reality. The COVID-19 pandemic was a powerful reminder of how grief affects healthcare workers. Many medics experienced loss on a scale never seen before. Patients, colleagues, even family. And often they didn't get closure because funerals were limited or families couldn't visit. The lesson here is that healthcare systems need to support not just physical safety, but emotional well-being too. As future medics, advocating for mental health support is part of the profession. To close, I want to emphasize that grief is not a weakness. In fact, it's a sign that you cared. The best doctors aren't emotionally numb, they're emotionally aware. That doesn't mean being overwhelmed by every loss, but finding healthy ways to cope and reflect. Remember, you cannot truly heal others if you ignore your own emotions. Thank you for listening.
Thank you very much, Neha. That was honestly really relevant to every medical doctor, every medical, healthcare professional, because you will experience losses. Maybe some of your favorite patients, they might be rehabilitated and then maybe their condition worsens. And so, yeah, that is a very relevant thing that a lot of healthcare professionals struggle with. And yeah, so I hope you guys enjoyed that seminar. I was going to say lesson. And I'm going to send in the attendance form. Please fill that out, and then if you have any questions, we'll be, here at the end. But yeah, thank you so much for joining, and please keep in your head the reminders that I mentioned. If you would like to help us make the video, that'd be really helpful.